Event around World Pneumonia Day. We are very proud at Shot at Life to be co-hosting this with IVAC. A lot of work has gone into this event, and I think we've got a great program lined up. We are going to start out with a video message from somebody who would have loved to be here, but is at another event, and that's Oren Levine. He's at the Gates Foundation, but I think a lot of you know he used to be at IVAC and was part of the team that started World Pneumo Day.
Wow, World Pneumonia Day is 10. Welcome everyone to this great event in commemoration of the 10th year of World Pneumonia Day. Wish I could be with you in person. It's incredible for me to even think that World Pneumonia Day is now 10. It started with very humble beginnings. A small group of people challenged, frankly, by a socially conscious hedge fund manager who heard at a meeting that pneumonia killed more children than any other disease and simply couldn't believe it. And he couldn't believe it because he couldn't believe how much needed to be done and wasn't getting done. That's why World Pneumonia Day started. That's why it's as important today as it was 10 years ago. So I can't wait for you to get to hear from the fantastic speakers, the many different examples of progress that have been made in the last 10 years, contributing to the lowest level of pneumonia deaths in kids ever, but also a reminder of the challenges ahead, of the really important work that we need to do in order to continue to combat childhood pneumonia. So best wishes, have a great event, and let's go World Pneumonia Day.
So Kate, I'd love to get us started with some questions, if that sounds good, and at the end we'll open it up to the audience.
Yeah, for sure.
Great. So this week, as a lot of you know, is Childhood Health Week. Yesterday was World Pneumonia Day, and a lot of progress has been made. So the Gavi rollout of the pneumo vaccine has prevented deaths of 500,000 children in the last 10 years. We have new tools to diagnose and to treat pneumonia, and when they're deployed widely and with high quality, they work. But what remains to be done, you know, can you fill us in on what's the work that remains to be done? Because we have all these great tools, progress has been made, but still too many deaths, I think we'd all agree.
Yeah, I think the first thing that we should just acknowledge, as Oren did, is that we have the lowest number of pneumonia deaths and diarrhea deaths ever, right? So we should at least acknowledge the progress that we've made in really a relatively short period of time. You know, from the year 2000 to 2016, we've gone from 10 million child deaths down to below 6 million. We've gone from 2.5 million pneumonia and diarrhea deaths to 1.3 million. So we have tools that work. And we know those tools work because we've got lots of countries where pneumonia deaths and diarrheal deaths, but let's focus on pneumonia, is really not why children are dying.
Right.
So this is not a disease like some of the other ones we have where we really have no tools, Lassa fever or Marburg or something like that. We actually have an incredibly effective toolkit. But we're not there yet. There's still millions of children who die from pneumonia all the time. And so for me, there are sort of three key advances that are needed as we look to the future after having acknowledged and celebrated, you know, where we've come from. And the first is we have life-saving vaccines against pneumonia. We have Hib, we have pneumo, we have measles, we have diphtheria, and they are not yet in every country. And they're not, all of them are certainly not getting to every child in the full schedule of what kids need. So we have an unfinished business in terms of deploying these life-saving vaccines. The second is caring for ill children. Just because you get a vaccine doesn't mean that for sure you're not going to get pneumonia. We don't have vaccines against all causes of pneumonia. So we need improved diagnostics, and we also need improvements in access to care and care seeking. And I think one of the things that really strikes me is when you think of the pneumonia deaths, a very substantial number of those pneumonia deaths, a substantial fraction, die outside of facilities. That doesn't happen in high-income countries. When children are ill enough that they seek care at hospitals, when occasionally a child does die of pneumonia, they die in a facility having got as much care as could be delivered to them. Yep. So the fact that we have a substantial fraction of kids who die outside the facility means either there aren't the kinds of treatment available to them, or parents are unable to get it, or they don't even recognize the signs of pneumonia, and so don't know to seek care until it's too late. And the third is that a child who dies of pneumonia or who becomes very ill from pneumonia is not the same as every other child. These are not random children. So we have a lot of understanding of who are these kids. And they are children who have disproportionately other conditions. They're underweight. They have terrible exposure to indoor air pollution, usually through cooking. They may be born to an HIV-infected mother. So many children who die of pneumonia have not just one risk factor, but have risk stacking. And so we have really these sort of three ways of trying to intervene to reduce these deaths and illnesses moving forward.
Yeah, that's great. So we hear a lot about data. Data is gold. We're hearing it not only in global health, but across all sectors, right? The data allows us to, I mean, we can ingest and analyze more data than ever in the past, and data allows us to recognize patterns and create efficiencies. So can you help us in how data, fill us in on how data might be able to help us combat pneumonia?
Yeah, so I'm so glad you asked about that, because I'm a data person. This is I love data, right? Who doesn't love data?
Right.
What's wrong with you if you don't like data? Anyway, I guess one of the things that I say is you cannot effectively change something when you can't measure it.
Yeah, that's great.
You don't know what to do. You're blind to what should be done. So for me, I think advances in data are really essential. And when you look at what we're talking about in terms of data, I think a lot of people have a reaction to that, like, oh, God, a bunch of scientists who want to just collect more data. But what we're really talking about is data in the hands of people who take action.
Yeah.
And for me, where the data needs to sit is at the people who actually deliver interventions. So if you're a community health worker, or if you're a nurse, or you're running a vaccine clinic, for example, or a treatment facility, a clinic, you have no idea how to improve the actual outcome of children unless you know, well, how many kids am I supposed to vaccinate? Where are the births happening? Who are the kids who got their first dose of vaccine but didn't get another dose of vaccine? So for me, when we're talking about data, we have to move from a system that was designed 40 years ago, which was basically pencil and paper. We're now almost at 2019. You can be absolutely sure that Amazon and Facebook, they are not accruing the wealth and the impact that they have because they're using pencil and paper. So I think, the public health community, and especially the vaccine community, which is my area of interest, we really need to sort of spring forward into that. We've had really uneven progress in sort of data, and especially in measuring data at the subnational level. And that's really where the story is not just at the country-by-country level, but what's happening really underneath the hood at that very subnational level.
Yep. Okay. Well, interestingly enough, about data, IVAC just came out with its annual report, Progress on Pneumonia and Diarrheal Disease. And for the first time, you sliced the data a little bit differently. Can you talk to us a little bit about that, and talk to us about, as you said, this sort of uneven distribution of where we're seeing pockets of pneumonia still?
Yeah, so this year we just really felt in IVAC that the story is in the data and the story is in the subnational data. And so we wanted to see what we could do with respect to subnational data. And a few themes came out for us. The first is that shining a spotlight on this is really important because we actually had quite a bit of difficulty doing an analysis at the subnational level because of the lack of availability of subnational data. The second thing is that our report is referred to as a progress report.
Yeah.
So progress implies that you actually have to compare a past experience to a current experience, and that would require more than one piece of data on the same outcome.
Right.
And that was really, really challenging. Of all the metrics that we monitor, less than half of them had new data compared with last year. So although we report progress, I think we all have to acknowledge in this world that we work in is we actually can't effectively measure progress. And to me, that's also about accountability.
Yeah.
Which is, unless we're able to show what the investments are doing, we cannot be accountable for the impact of those assessments.
Right.
And we can't pivot. We can't assess what's not working so that we can try something different, so we can innovate. So this is just a really critical sort of aspect of the equity issue, that in our report, there were really incredible inequities across countries, yes, but also deep within the country at the subnational level, where maternal education, geography makes a big difference. In some countries, gender of the child makes a difference. So this is, to me, what drives the changes that we should be making at that subnational level in the program. It's not a one-size-fits-all solution as we move forward.
That's great. That's great to hear. And I know we feel we have learned a lot since the big effort to immunize, and data being a really important thing, as you said, breaking it out sometimes by gender, and sometimes even within a country and within a city, there can be great inequities. So you have a room of a lot of advocates here. What can we all do to help in the fight to combat childhood pneumonia? What are some of the things we can do to forward the progress?
Yeah, so probably there are a few areas that I think we can do concrete things. The first is to ensure that the funding not only stays in place, but wherever possible that we can accentuate it. And we have to be really clever about how we use the money to get the greatest impact. So in particular, we're sitting here in Washington, a call to the U.S. government that is, the parts of the U.S. government that fund the financing of vaccine programs, immunization programs, has been incredibly impactful, and that needs to stay strong and needs to be an ongoing and wherever possible increase in commitment. We know that most poor children don't live in poor countries. They live in middle-income countries. And those countries are not having the same access that the poorest countries now have. So I think as we move forward into the next decade, we really have to focus on how we're going to address that. I think the second thing is we should not be siloing vaccines. The vaccine program is really the flagship program in a way for public health interventions and community-based interventions. I'm a real proponent not of a vertical and not of a horizontal approach. I'm a diagonalist. I'm not even sure if that's a term, but
I like it.
That's how I consider myself, a diagonalist. The vaccine program is the most widely deployed program and frankly, is an anchor for the health system. And we should find all the ways in which we can integrate that program. Children are not vaccine recipients. They're children.
Yeah.
And they come usually with a mother and a father, or two mothers or two fathers. So really we should be envisioning how these programs can serve the needs of those families and those children so that they get all of the interventions that they need at that one visit when they're there in front of us, whether it's vitamin A, whether or not it's growth and resilience interventions, whether it's deworming, whether it's family planning for the mother.
Yeah.
I know as a mother myself, it would make me crazy if I had to come one at a time for every single thing I had to do.
Yeah.
So that's what these families deserve, and really we should be focusing on a sort of human-centered design about how to make the vaccine program, more deeply engaged with the family.
Is there any easy or straightforward way to address this issue?
What a great question. It makes it sound quite easy to just say we just need better data and we need to analyze it, and probably all of us sitting here in this room think, well, I kind of do that every day. I do that with my own finances. Like, how hard could this be? This is actually a really heavy lift. It's a heavy lift in part because we don't want to silo particular programs in one data system. The health worker is not only a vaccine health worker, they're a health worker for lots of other interventions. And so we don't want to have to boil the ocean and say we can't make any progress unless we design data systems for the whole of the health system. So I don't think we want to err on that side, but neither do we want to end up with a completely incoherent system for the actual users of the data, where they have one system for vaccines and another system for family planning and another system for nutrition. That's crazy making. So this is going to be a long road, but we've got all kinds of tools at our disposal and smart, effective designers who can work in countries to help them sort out what's best for the country.
Great. Time for maybe one more question. Any other questions? I see in the back.
Yeah, there's surely innovation that we need. I think one of the biggest issues that we have to face for pneumonia moving forward is that the vaccines that were developed 20 years ago were developed appropriately based on data about what the major causes of pneumonia were. Those were Hib and pneumococcus that largely were the pathogens, the germs that were causing death. And we have great vaccines against those bacteria now. So the question is, are our treatment algorithms now still appropriate when we've actually dealt with the evidence on which we develop those algorithms is actually an outdated evidence base. We've done what we were called to do by that evidence, and we really need to be looking to the future about what are kids dying from now as causes of pneumonia. Are our treatment algorithms appropriate? Can we start to tease off some of the kids who come in who actually don't need antibiotics but need supportive care? So we need some innovation moving forward around diagnostics. We need innovation moving forward around parents recognizing signs and symptoms. We probably need innovation around new antibiotics. And we certainly need more innovation around the next tier of vaccines to deal with the remaining low-hanging fruit, especially RSV as a virus. So we're not there yet, but I don't want the message to be that we don't have tools now in our toolkit to deal with what we've got in front of us still. We have really effective tools. We can do better with more innovation, but we should get on with the business at hand.
Great. Well, thank you so much, Kate. If we could give her a round of applause. Excellent. And now I'd like to introduce our next speaker. Stefan Peterson is the chief of UNICEF's health section. He's also a professor of global health at Uppsala University. He's an experienced health systems researcher and medical doctor who has done extensive field work in Tanzania and Uganda. He's the co-founder of Médecins Sans Frontières Sweden and the CCM Task Force Operations Research Group. So welcome.
Thanks, Martha. That was a mouthful.
It's an impressive background. So Dr. Peterson, in your role at UNICEF, I know and your work in the field, you've thought a lot about pneumonia. Why in particular have you been so engaged and focused on pneumonia?
No, I'm putting my hand up now because I'm a pneumonia survivor. I don't know. How about you? Are there any other pneumonia survivors here in the room?
Yes, there are quite a few. Look.
I mean, there are several hands in this room, and what really upsets me is that there's 850,000 kids this year who won't be able to put their hand up. And in spite of the progress that Kate referred to, it's so bloody slow, in plain English, for pneumonia. And that really upsets me. And I'm appalled that the world's biggest infectious disease killer is actually a neglected disease. Mm. And that's such a paradox, I think, and that really upsets me.
Okay, good. All right. Well, I think there'll be a lot of us who will want to hear about it, an action plan around that. So what do you think are the major issues? I mean, as you said, how is this still killing so many children?
No, I think it's sort of pneumonia is a disease of the poor, as we heard from Kate.
Yeah.
And
great point.
Actually, if you live here in Washington, you don't feel threatened by it. No. Unless you sleep in the street or something, right? Mm-hmm. So that's probably explains why pneumonia is an orphan disease. And as a consequence, there is no global fund for pneumonia. There is no presidential pneumonia initiative. I think it'd be a great idea, PPI, wouldn't it?
Yeah, because we know it kills more children than malaria, than tuberculosis.
Oh, yes.
Yeah.
and diarrhea and all of that, right? So
yes.
we're way ahead there. But it also, coming back to Kate's points, we fail to look at it from the household perspective, because me as a parent, my kid would have a high fever in the middle of the night. And in the kind of world that we've designed, starting in Washington, New York, and Geneva, I would go to the health center and you would tell me, Stefan, congratulations, your child does not have malaria.
Yeah.
Which is, of course, fine. But then what? My kid is still sick.
Yeah.
So what am I going to do? Am I go to the shop on the corner and buy some antibiotics and self-medicate? I mean, this is Antibiotic Awareness Week, and that's sort of what's happening. So we're failing the kid by taking a siloed approach, one disease at a time. We're failing the parent, and we're failing to build sensible health systems that actually have a supermarket approach, so we don't have to keep running there every day of the week, as we heard from Kate. So people like to think about last mile health systems, but I think that's the wrong conception. That's, if you sit in a hospital, you want to think about the last mile. But if to you as a parent, it's about the first mile health system, isn't it? My kid is sick at home in the middle of the night, and where do I go within that first mile? So I think we need to design our support systems, if we truly care about children more than diseases, to cater for that. And I think that would be a good message to take. And actually, as I'm sure that many of you advise people who sit on various boards and so on, to think about, turn it around, a first mile perspective, a child perspective, and a caretaker perspective, and say it's not about diseases ultimately, it's about children. And how can our systems help that?
Yeah, I love that perspective. And UNICEF has been great at putting the child at the center of everything. Thank you for that. So again, the question I had for Kate at the end, what can we all do about this? You know, this is something we all care about.
Well, obviously, I think many of you in this room, you should actually work on getting more investment to pneumonia as a neglected disease. And I think it's a bit of a paradox in the sense that we need to make noise about pneumonia as an individual disease, but the response needs to be integrated, particularly on the curative side. I don't need to talk about vaccines because everyone else is talking about vaccines here tonight.
Right.
But even so, even if and when we succeed to get that 100% vaccine coverage, there'll still be sick kids in the middle of the night, and you still have to exclude that this kid could benefit from an antimalarial or an antibiotic, etc. So we need those investments in research. We need that fever diagnostic. And we need that diagnostic that doesn't necessarily talk about whether it's one bug or the other, but it says, does this kid benefit from an antibiotic or an antimalarial? Much more management-oriented stuff. That said, we do have tools already, as we've heard. We have vaccines, and we need to increase the coverage there, and the price needs to come down.
Yes.
We also have a great innovation called amoxicillin, dispersible amoxicillin. Which is half the price compared to the syrups that I grew up on. I don't know about you. You remember those messy syrup bottles? At any rate, we also have discovered something remarkable called oxygen. Have you ever heard about it? I mean, it's something
But
you
not
need.
available. in a lot
But
of
not
places,
available. So
right?
we have systems. We as UNICEF, we work with Gates Foundation, we work with others, we work with like Kaiser Foundation on getting more respiratory rate counters. Even in this day and age, counting respiratory rate is the best thing that is out there, awaiting better diagnostics. So the issue is, Martha, putting those things together in a systems perspective so they work together, because as standalone pieces, beyond immunization on the curative side, they don't do all that much. So you need a system. So we've actually, and I'm announcing that, this is great, I get to announce a $4 million investment. Maybe some of
Great.
you picked up a sheet that looks like this. It says Sprint. Our executive director, Henrietta Fore, is very keen on
Yes.
actually on innovation and going to scale. She launched this thing thinking about project bundles, putting the amoxicillin dispersible together with the oxygen, together with the diagnostics that we have, that we are developing, together with program management guidelines, and building a scalable model. So she put $4 million down, so we can do that in 2 countries now, actually saying here's a scalable model of a curative pneumonia bundle. So we're looking for partners actually to do that in a lot more countries.
Great. So that is a new program called Sprint.
Sprint,
and
yes.
And there's information available. Is that by the registration desk?
I think so. Did some of you pick this thing there?
Yes.
Yes, thank you.
Excellent. And it's in 2 countries right now, looking to expand to more.
Correct.
That's fabulous. Great. Well, I'd love to open up to questions if anyone has any questions for Stefan, for Dr. Peterson. And if not, I think he will be around afterwards if people are shy to ask.
Stefan, I have a question for you about the Sprint. I have a question for you about the Sprint initiative and maybe a little bit of a challenge. And this sounds like a fantastic opportunity to actually integrate. And what I mean by that is the child who's coming to the facility who's going to benefit from this integrated oxygen, amoxicillin, the interventions, is the same child who almost certainly is under-vaccinated. Yeah. And we do a terrible job of identifying when that child is right in front of us. It's not about whether we can find them or anything, but actually vaccinating that child when they're there for curative services. So just an idea and maybe a challenge that could Sprint incorporate as part of its integration, the evaluation of immunization for that child and make sure that when they leave, having been cured of their illness, that they're up to date with their vaccines.
No, it's great. I think it's the systems thinking that we so often fail to do. We're so focused on innovating a new gadget or fixing the problem of the day that we fail to think about the system. So I agree with you totally there.
Great. Any other questions? Good. Okay. Well, thank you so much, Dr.
Thanks, Martha.
Okay.
Great to be here.
So our next speaker, looking a little more forward, is Natasha Villamoria, who's the Director of U.S. Strategy for Gavi, the Vaccine Alliance, where she leads efforts to mobilize U.S. support for childhood immunization in the poorest countries. Prior to this role, Natasha served as president of Friends of the Global Fight and held positions at the Elizabeth Glaser Pediatric AIDS Foundation and as staff in the White House. That's pretty fancy. Welcome, Natasha.
Thank you. It's
We're
great to
glad
be here.
have you here. So Gavi has been key in the fight against pneumonia, making the pneumo vaccine affordable and available in the poorest countries. Can you explain a little bit how they do this?
Sure.
And what that means?
Yeah, absolutely. So, Gavi's mission is really to bring new and underused vaccines to some of the poorest children in the world. And I actually think the pneumococcal vaccine is actually a great example of how Gavi's model was able to do this. So just to back up a little, the vaccine first became available in the U.S., I think in 2001, in the early 2000s. And while it was clearly something we needed in this country, the impact of pneumonia in the developing world was huge. And children in poor countries needed it just as much, if not more, actually. And so, the disease was having a negative impact on kids. And really what we needed to do was not only ensure that countries around the world had access to the vaccine at an affordable price, but we also needed to make sure that the vaccine was the right vaccine for the kind of pneumonia that kids were getting in poor countries, because the strains were actually different. And what we were able to do about a decade ago, actually, was launch something called the Advanced Market Commitment. And what that is, it's also known as the AMC, if you've heard that acronym before, and it's really an innovative financing mechanism. And what it did was it allowed donors to come together and basically pledge to put money forward to accelerate the development of a pneumococcal vaccine that was appropriate for the developing world, but also at a reduced price. So the simple mechanism was donors put up money, industry saw that there was a market for it and saw that there was a market for that particular vaccine, and then they were able to develop it and accelerate it, and we were able to get it out. And it really was, groundbreaking in that in most cases, historically, vaccines that were coming to poor countries literally could take a decade to get there. And with the pneumococcal vaccine, along with the AMC and a lot of advocacy, we were able to get that vaccine out in less than 12 months after the vaccine was pre-qualified by the WHO. So that was really groundbreaking. And, to date, 143 million kids in almost 60 Gavi-supported countries have been immunized. And in fact, the government of Haiti just announced that they're going to be introducing the pneumococcal vaccine into its national routine program, and which could, nearly vaccinate 300,000, which would reach 300,000 kids in Haiti each year.
That's fabulous. And for context, as some people in the room may not know, the pneumo vaccine is among the most expensive ones. So really to have a mechanism for countries like Haiti and others that would never be able to afford it, what a tremendous value that's
Yep.
been. That's really great. Can I ask, what are the next steps that Gavi is going to be taking to combating pneumo? We've heard about a diagonal approach. We've heard about the importance of strengthening health systems, and then when people come in to get a vaccine, make sure you're doing some of the wraparound services. How does Gavi see the future of combating pneumo? Because you have some countries who will be graduating. Not all countries participate. I'd love to hear your view on moving forward.
Well, I think while Gavi and the countries have done a great job in introducing the vaccine, not every country has, and so we need to make sure that that continues. I think that also we, just to step back, and I think this answers your question, but also in a broader way, is that, we really also need to be looking at what are the barriers to immunization, more generally, and why, we still have 20% of kids still not getting the vaccines we need, and what are the barriers to that? And so the Alliance is really working together, in a number of different areas. Kate talked about data quality, which is hugely important, but also looking at improving in-country leadership, demand generation, and also around supply chains, because all of those things really make an impact on the ability for, that shot to go into a child's arm. And so, we are working with our traditional partners, but also working with new types of partners, and that includes the private sector. We signed an agreement a couple of years ago with Unilever, a big company in India, on both pneumococcal and rotavirus. And what we're doing there is really using their expertise in marketing, and also they're providing some financial support, but using that with Gavi's health systems and expertise in immunization to really ensure that that demand generation piece is really at play, and people are really pushing for getting that vaccine. Another thing we introduced a couple of years ago is an innovation platform called Infuse. And what that does is really take existing technologies, but using them to scale on immunization. So these are technologies that exist for other things. They're not for immunization in particular, but they can be applied to what we're doing to then, scale. And this year, our call actually related to digital identification, because I think actually both Stefan and Kate talked about how, we've got to identify these kids. And we're, working with some really interesting companies using new data technologies on figuring out how do we identify these kids who, sometimes they are standing right in front of you, but oftentimes they're not. And, finding out who they are and then literally giving them an identity that then can be used to ensure that they are getting the vaccines they need, and we can see what they've been, what they've been given and what remains to be had. So, I think we're really working, sort of again, in some of the traditional ways we have been, but also looking at new ways of overcoming, the larger barriers we're seeing with getting to that 20%.
That's great. And I heard today earlier even talking about investing in human resources. So even helping within country, thinking about the fact that they might need help in everything from accounting to scaling up. And so being able to understanding that could be an important element.
Well, I think actually it's been shown, and we've been working, in this area in particular on really the management training of, the folks, in EPI in country, ensuring that they have the budgeting skills and things like that, because those are also critical to ensuring that these programs work overall.
Yeah, that's great. It's great to hear about all these different aspects. And I know when I was in the field in Uganda, I saw a truck that had Gavi's logo on it. So I know that you support many parts of the cold chain too, and refrigerators. It was part of the Rhoda
Yep.
rollout, I think. So that was fabulous to see, recognizing that, as you said, in order for the vaccine to get in the arm or the leg, there is a lot of other things that need to be in place.
That's right.
So
And we
that's
rely on our
fabulous.
partners on the ground to do that, UNICEF being one of them, so.
Yeah, great. So we've talked a lot about what Gavi has accomplished, and it's been a tremendous amount, but maybe you can help fill us in on what have been some of the challenges and what have been some of the learnings.
Yeah, well, I think that, in talking about the AMC, I think we've seen a lot of success. I think a lot of the goals that we set out to accomplish have occurred, getting that price lowered and creating a good bit of supply. But, I think that one of the things that has been difficult is the pneumococcal vaccine is complex. It's not an easy vaccine. And so, what we really need to be doing and what we're focusing on.
Just to interrupt, complex in that it has the 13 strains, or complex in that?
It's actually complex to manufacture,
Yeah,
right? So
right. Okay,
it's
that's what
more
I thought you meant.
technically complex. And, and I think a place that we are still working on is adding suppliers to the mix.
Yeah.
And, we've had one that came in, I think, in 2017 that's, going to be starting. But again, I think this is a place where we need to get more actual suppliers into the mix to really create what would be a healthy market and ensure that we've got the supply that we need. But, on the flip side, what I would say is, we've actually, it is a very expensive vaccine, but we've been able to reduce that price.
Yeah.
And actually, recently, it just came down to under $3, about $2.95 a dose. And actually, by 2027, that, will save over $50 million in the purchase of the vaccine. So, there's been success, but there's obviously still continued work that needs to be done.
Yeah, great, thank you. So as a wrap-up question, how does Gavi see the future? What are the important things that need to be done to combat pneumonia? I think all speakers have agreed their progress has not been fast enough. A lot more needs to be done. How does Gavi envision?
Well, I think, the first thing is really ensuring that all the countries are introducing the vaccine into their routine systems. I think we will see, both for Rhoda and pneumo, those numbers go up. India is about to start rolling out the vaccine, and given that they have the largest birth cohort in the world, that I think that's a major plus. But I think we have to continue ensuring that countries are introducing, but also ensuring that the coverage within the country is happening as well. So it's not only introduction, it's about coverage and equity within a country. I think that, just to build on what IVAC's report stated and what Kate said, I think data quality is also another piece that is critical to what we do. It's, not only about finding the kids, but, even understanding what the coverage levels are and making sure that we have quality data, to really understand that, I think is critical. So data is, I think it's important to everybody, and Gavi is no different. And that's really, a place where, we want to focus on as well. And I think overall, it's about really continuing the work with our partners. It's the civil society, it's, the countries themselves, it's the donors, it's our partners, and really, really working together to ensure that we are able to overcome the challenges we're seeing and really ensure that every child is getting the immunizations that they need to live a healthy life.
So thank you so much for your remarks. Do we have any questions for Natasha? We have time for just one or two questions. A mic is coming.
So thanks a lot for your insights. I was wondering, since a lot of the focus is on the poorest countries, often, as Dr. O'Brien mentioned, a lot of the children who don't receive vaccination are in middle-income countries. So what kind of approaches can be used to ensure coverage and affordability in those kind of scenarios?
So that's a great question. And, Gavi, its focus is on, poor countries around the world. But it's interesting because we do have some countries that are considered lower middle income countries. And what we're seeing with some of those activities is those countries are actually doing better than countries that have never received Gavi support. And I think that there are definitely some lessons learned there. And, this is an area that we're actually thinking about. We're in our current strategic cycle, but that ends in, this cycle ends in 2020. And so what we are doing is actually in the process of really thinking through what our next strategy is. And this is actually a very important question that is being raised. And again, it wouldn't be done in the same way because middle-income countries have resources that are very different than poor countries. But again, what are some of the lessons that we've learned that could potentially, be applied to countries like that and to get the coverage rates up? Because you're absolutely right. Those countries do have issues with them.
So we're hearing that there might maybe not Gavi directly financing, but sharing best practices or lessons learned with middle-income countries or working,
I think these are all discussions that
Yeah.
need to be had.
Yep. As Kate said, some of the poorest in the world are living in middle-income countries. Please.
Hi, Natasha. Sorry, in the spirit of Kate asking me. Last week, I was in Beirut, and I sat in an urban slum with the Syrian refugee family, which was 10 minutes from a vaccination point, and they had been immunized, etc. Not for geographic distance, but for social distance, and not being registered, not being this, not being that, not knowing what it would cost, etc. And Lebanon, with its small population, now has 1.5 million Syrian refugees in a middle-income country, where I know under the current strategic plan, Gavi does not extend. And at the same time, when you leave the Gavi umbrella, the $3 per pneumococcal vaccine dose goes up to, what is it, 15 or 50 or whatever. So I guess my question is, and with my old Médecins Sans Frontières hat on, what is it we can do actually to keep vaccine prices low once you graduate from the Gavi purchasing umbrella and to reach vulnerable populations also in middle-income countries?
Well, so I think I'd say a couple things. So one, the country that you're speaking of, it was never a Gavi country. So I think that's part of it. But, one of the things that we have been working very hard to do is to ensure that as countries leave the Gavi family and they are, transitioning out of Gavi support, that they do get access to those prices for a certain period of time. And at our last replenishment in Berlin, we had a number of manufacturers actually commit to providing a Gavi price to transitioning countries between 5 and 10 years. And, those are things that we are continuing to advocate for. But it is an important piece because, again, financial sustainability of these programs are critical, and obviously, we need to ensure that vaccines are affordable for them too. And again, Gavi has been working with the manufacturers to ensure that as they transition, many of the vaccines are available at that cost for a period of time.
Great. Are there any other questions for Natasha? Good. Well, please join me in a round of applause for our fabulous speakers. And I know they'll be around. There's plenty of food and drink left, so please enjoy yourself, and thank you all for coming.